those were the intrinsic mechanisms of regulating GFR. Let's talk here about the extrinsic control of GFR. So on your graph, I want you to kind of make a note that when we speak about the intrinsic mechanisms, we're really speaking about keeping GFR at 125 as long as mean arterial pressure is in this window of 80 to 180. So you can go ahead and write the intrinsic mechanisms, which are the three mechanisms that we just talked about, within this window. When we speak about extrinsic controls, we're really speaking about decreases in blood pressure that do cause a decrease in GFR. So beyond that 80 to 180 window, the kidneys will eventually waver the GFR. The GFR will either drop if mean arterial pressure drops or rise if mean arterial pressure rises. So you can write the extrinsic controls out here. So the extrinsic controls are going to be less than 80 and greater than 180. And what we mean is that GFR will change in the face of changing mean arterial pressure. It's going to directly decrease in filtration pressure. So we're going to see a direct drop in filtration pressure. And then it's going to happen indirectly through some other extrinsic controls that we'll talk about. So here is an example of that extrinsic control. So let's say you're hemorrhaging or you're sweating profusely and your mean arterial pressure drops. But in order to understand the extrinsic part of this, the mean arterial pressure drops below 80 millimeters of mercury. So I want you to make a note in your flow chart here that this hemorrhaging and sweating results in a drop of mean arterial pressure less than 80 millimeters of mercury. Okay, that's where we get into the extrinsic controls that we're talking about. So that drops blood volume, and as blood volume drops, venous pressure drops, right? The amount of pressure that's in our veins. And as that drops, venous return drops, right? If we've got less pressure in our veins, that's less blood coming back to the atria of the heart, the right side of the heart. And so venous return decreases. And if the heart is not filling adequate quantities of blood, then it's not going to pump adequate quantities of blood. And as a result, cardiac output will also decrease. Now, when cardiac output decreases, we should know this, that mean arterial pressure is going to drop, right? If the heart is not pumping adequate volume, mean arterial pressure takes a hit. Now, what happens when mean arterial pressure drops? This triggers baroreceptors to detect this drop in mean arterial pressure, and they are going to respond by increasing sympathetic nervous activity, right? This is something that you should have talked about in the cardiovascular system, right? This baroreceptor, this stretch receptor response. So as the pressure drops, there's less of the stretch that's coming across these mechanoreceptors, these baroreceptors. And so they're going to result by increasing sympathetic activity in order to help restore this mean arterial pressure. That increased activity has an increased effect on the kidneys by vasoconstricting or clamping down or decreasing the lumen of the afferent arteriole and the efferent arteriole, and that is going to increase the vascular resistance, which is going to decrease the GFR, right? If we're decreasing the flow, the amount of filtered, the amount of plasma that's being filtered is going to decrease, right? So that's going to be a drop in GFR, and then urine output is going to decrease and fluid loss is going to decrease. So that is the intent behind this extrinsic control. If I'm hemorrhaging, if I'm sweating profusely, if I'm extremely dehydrated, my kidneys need not keep GFR constant at this point. They need to now decrease the GFR so that I don't lose too much fluid, so that I don't die of shock or die of hemorrhage, okay? And so this is what we talk about, this is what we mean when we talk about the extrinsic mechanisms of controlling GFR. So here, it's going to be beneficial to us to drop GFR in the face of a decreasing blood volume or in the face of a decreasing mean arterial pressure. That is going to basically keep us alive, right? If you're hemorrhaging or sweating, you don't want to just keep GFR because that's going to mean you're going to lose more fluid than you need to. You actually want to drop GFR so that you can hold on to some of that fluid. And the negative feedback result is going to restore blood volume as we hold on to more fluid by losing less in the urine. We're going to hold on to some of that blood volume and potentially restore blood volume, which will turn off that negative feedback, that initial stimulus of a drop in blood volume. Okay. All right. So this is the indirect mechanism. We also want to point out the direct mechanism of this happening. So the direct mechanism is that when we drop mean arterial pressure, right away the GFR drops. So there are two routes that this is brought about. The direct route is that drop in mean arterial pressure drops GFR, and a drop in GFR will eventually result in a drop in fluid loss, which will eventually restore blood volume. Okay. So let's pause here and let's see what questions you guys may have. And just to kind of recap, we talked about the structure of the nephron. We talked about the filtration barrier, so the three components of the filtration barrier. We talked about the, as far as filtration, we talked about the Starling forces. We talked about the intrinsic mechanisms of maintaining GFR, and then we talked about the extrinsic mechanism of maintaining GFR. All right. I don't see any questions. Now, I want you guys to kind of work on these checkpoint questions. So you can go ahead and take a screenshot of this, or this will be available on the replay if you're watching this again. But try to work on these questions, try to write down an answer. And when we will convene during our next class, we'll start off by looking at the responses to these questions. Okay, it's going to be really important. Bear in mind that your exams are now written response, so you really want to work on being able to express the answers to these questions in a written way, in a written format. All right, so we've kind of completed the first renal exchange process. So let's recap here a little bit. We talked about there being four main renal exchange processes: filtration, reabsorption, secretion, and then excretion. So we talked extensively about the first one, which is filtration, the movement of plasma across the glomerulus, across the glomerular membrane into the Bowman's capsule. Now we're going to move on to the second renal exchange process. This is called reabsorption. And the basis behind this process is the body needs to reclaim important substances that it does not want to get rid of. And for one, that's going to be fluid, right? We talked about the fact that not all of the fluid that is filtered is actually leaving the body as urine. In fact, 99% of that fluid is reclaimed or reabsorbed back into the body. And this happens by the movement of these substances, including water, from the tubule, specifically the first part of the tubule, the proximal convoluted tubule, back into the peritubular capillaries. And these are the capillaries that are intimately connected to the proximal convoluted tubule. So basically, we're returning these substances and water from the tubule back into the blood. Okay, most of this is not regulated, meaning that it just happens. So if there's glucose present, all of that glucose is going to be returned back into the blood. If there are amino acids present, all of those amino acids are going to be returned back into the blood. And so when we say that it's not regulated, it's not changing. It doesn't happen. It doesn't fluctuate based upon any other circumstance. Versus something that is regulated, if a lot of it comes through, more of it will be reabsorbed. If a little bit comes through, less of it will be reabsorbed. That is not the case here in the proximal tubule. It's not regulated, so all of whatever comes through is reabsorbed back into the blood. Okay. This table, I don't want you to memorize, but I want you to have an understanding of some of the proportions, right, of what is reabsorbed. So these are our rates of filtration. So how much of these substances are filtered across the glomerulus? These are our rates of reabsorption, how much of these substances are reabsorbed back from the tubular structures back into the capillaries, so back into the blood. And then here is a percentage of that filtered load. So how much of that how much of what was filtered is actually reabsorbed, okay? So in terms of looking at the proportions here, we can see that of the filtered glucose, all of it is reabsorbed. And what this tells us is that there should never be glucose in the urine. We're going to talk about this a little bit later on, but glucose should always be reclaimed back into the blood. We should never have glucose in the urine. And when we start to see glucose in the urine, this is an indicator of excess glucose, excess blood glucose levels, meaning diabetes, right? Diabetics are the only ones that we see, or persons with other kidney dysfunction are the only people that we see with glucose in their urine, but glucose should not be in the urine in normal healthy adults. And that's because 100% of it should be reabsorbed. Water, we know that 99% of it is reabsorbed, so most of it is reabsorbed. We talked about this before. Urea, about 50% of it is reabsorbed. Sodium, again, most of it should be reabsorbed. Most of the potassium should be reabsorbed. And most of these other solutes as well. So calcium, chloride, bicarbonate should be reabsorbed from the tubule back into the blood. And this is what I mean by the useful or nutritive substances that the body needs. If we were to lose all of the substances that were filtered, we would lose excess amounts of water, we would be dehydrated, we would lose way too much sodium, we would lose potassium, we would lose all of these vital electrolytes that the body needs, and we would definitely be in a state of shock. So most of these useful and nutritive and important substances are reclaimed back into the capillaries via the process of reabsorption. So solute reabsorption, most of it occurs in the proximal convoluted tubule. Some of it occurs in the distal convoluted tubule. We'll talk about that later on. And so we want to describe the barriers for reabsorption in a very similar way to how we talked about the barriers for filtration, those three structures that we talked about previously. We want to here identify the barriers for reabsorption. And the barriers are the epithelial cells of the renal tubule and the endothelial cells of the peritubular capillaries. So just to remind ourselves of this relationship between the peritubular capillaries and the proximal tubule. And if we look even closer, so if we kind of zoom into this relationship, we can see the barriers for filtration here. We can see the epithelial cells of the renal tubule, specifically the proximal part. We can see the peritubular space, so the small amount of space that's in between the capillary and the tubule. And then we can see the capillary endothelial cells that are lining the peritubular capillaries. Okay, so in order for substances and water to be reabsorbed, they must move from the lumen of the tubule across the epithelial cell of the tubule, across the basement membrane of the tubule, across the peritubular space, across the endothelial cell, and then finally make their way into the lumen of the capillary, which is back into the blood, okay? All right. And so here is an even closer view of these different structures of this barrier to reabsorption, right? So water is going to move across here. Sodium, chloride, potassium is going to move across here. And this is preventing these substances from being eliminated from the body with the urine, and we're reclaiming them back into the blood because we need them, especially glucose. All of the glucose is reabsorbed, and amino acids and important things like that. So let's describe reabsorption as the return of filtered molecules to the blood. So this is the return of molecules that were filtered across the glomerulus back into the blood from the tubular structures, from the lumen of the tubule. Now, 180 liters of water is filtered per day, and we talked about 1.5 to 2 liters being excreted as urine, and that gave us the proportion of about 99% being reabsorbed and about 1% or less being lost in the urine. Now, this will change depending on the hydration status. So if you're someone who drinks lots of fluid, you're well hydrated, you drink lots of water per day, the recommended allowance, I think, is something like 2 times your body weight in ounces should be brought in terms of the diet every day. And if you're doing that, then you're going to be well hydrated. And obviously, you're going to lose a little bit more than this 1.2 liters in the urine. On the other end of that spectrum, let's say you're completely dehydrated, you don't drink enough water, you're going to lose much less than this 1.2 liters. Obviously, you're going to lose closer to 1 or maybe less than 1 liter per day. But at a minimum, you must excrete 400 milliliters of urine per day as obligatory water loss. So in an effort to eliminate waste and eliminate excretory products from the body, a minimum of 400 milliliters must be excreted per day. And what that really means is that even if I drink absolutely zero water, even if I bring in zero water in my diet for the day, I still have to eliminate 400 milliliters of urine as obligatory water loss, okay? 85% of the reabsorption occurs in the proximal tubule and the descending loop of Henle, and these portions are unregulated. Again, unregulated here meaning that they don't change irrespective of hydration status, irrespective of body state, irrespective of whether you're hydrated or dehydrated. This doesn't change, right? In the proximal tubule and in the loop of Henle, this is unregulated reabsorption of water. We'll talk about the collecting duct and the distal tubule, which are regulated reabsorption. Okay, I think we're gonna kind of stop here because this is gonna get into the actual mechanisms of reabsorption, and I don't wanna get kind of halfway there. So we'll pick this up the next time we meet by speaking about the mechanisms, active transport, and so on, of how these substances and water are reabsorbed across those barriers to reabsorption, across the epithelial cell, the peritubular space, and then the endothelial cell of the capillary.